From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Good evening, folks. This is Dr. Paul. Thank you very much. Today I want to talk a few minutes about the treatment of bladder cancer. You see, the very easy process to do this is to remember the nature of the lesion. Is it superficial or invasive or metastatic? First, find that out. Once you find that out, the treatment is easy. Is it superficial, or is it invasive, or is it metastatic? Now, the probability of spread of this cancer increases with the depth of it. First, let's talk about superficial disease. At the minimum, the management of superficial tumor is complete endoscopic resection with or without intravesical therapy. So the complete resection, then the decision to recommend intravesical therapy depends on the histologic subtype and also the number of lesions and also the depth of invasion or the presence or absence of carcinoma in situ and then antecedent history. In general, solitary papillary lesions are managed by transurethral surgery, and carcinoma in situ and recurrent disease, they are treated by transurethral surgery followed by intravesical therapy. Now, intravesical therapies are used in two general contexts. First, as an adjuvant to a complete endoscopic resection, that means to prevent recurrence, or less commonly, to eliminate the disease that cannot be controlled by endoscopic resection alone. So those are the two contexts. And intravesical treatments are advised for patients with recurrent disease or when there is involvement of bladder more than 40% or sometimes even diffuse CIS or T1 disease. The standard intravesical therapy, based on randomized controls, comparative studies, is BCG. Remember that BCG we give in 6 weekly installations and followed by monthly maintenance administrations for 1 year. So BCG is the most important thing you need to remember. There are other agents like mitomycin C and interferon, and there is another agent like gemcitabine. And following the endoscopic resection, many times patients are monitored for recurrence at 3-month intervals. So you need to always monitor these patients for recurrent disease. And invasive disease. How do you treat the invasive disease? Find out how much depth the disease has spread. And then the treatment depends on two things. Number one, how to control the primary lesion. Number two, how to give the chemotherapy. So number one, controlling the primary. Number two, systemic chemotherapy. So controlling of the primary, you can do that either with the radical cystectomy, that is the standard, although in selected cases, more like sparing the bladder approach is also useful, including like complete endoscopic resection. So, or partial cystectomy. So radical cystectomy or partial cystectomy in combination with resection or systemic radiochemotherapy or even external beam radiation therapy. Now, what are the indications for cystectomy? They include muscle-invading tumors not suitable for surgical resection, or low-stage tumors unable for conservative management. For example, due to multicentric or frequent recurrences. So, if you see high-grade tumors, they are associated with CIS and bladder symptoms. then you should always go for radical cystectomy. Radical cystectomy is major surgery, and it requires appropriate preparative evaluation and management. The procedure involves, you remove a lot of stuff. You remove bladder, pelvic lymph nodes, and also you create a conduit or reservoir for urinary flow. So grossly abnormal lymph nodes are evaluated by frozen section, and if there is metastasis, and then you take a more radical approach. So radical cystectomy, in a male, you remove prostate gland, seminal vesicles, and proximal urethra. And if it is, almost universally the complication is impotence, unless you save the nerves that are involved in erection. Most of the patients end up in impotence. In females, you remove bladder, you remove the urethra, you remove ureter, you remove uterus, you remove fallopian tubules, you remove ovaries, anterior vaginal wall, and surrounding fascia. So a lot of stuff is resected in female patients. Now, previously, the urine was directed through a conduit and collected in an external appliance. But nowadays, more advanced treatments are available. Most patients receive either a continent reservoir constructed from detubulized bowel. So they take a small bowel and a piece of it, and they create a bladder out of it, or sometimes orthotonic neobladder. Many patients end up with neobladders nowadays. And 85% of patients, they develop continence with this approach. Sometimes patients also receive cutaneous reservoirs, and they need intermittent catheterization. And as neobladders nowadays are also used, and they have more natural drainage. So you see, you are creating an artificial bladder, and based on what kind of bladder you used, and you drain the urine from that from time to time. So you see, folks, three things: superficial, invasive, metastatic. Now what about chemotherapy? Chemotherapy can be used in combination with other treatments. Radical cystectomy or radiation therapy. And majority of patients, chemotherapy is not adequate, folks. For example, if you take metastatic disease, the primary goal of treatment for metastatic disease is to achieve complete remission with chemotherapy alone, or with a combined modality approach, like you use chemotherapy then followed by surgical resection, or if there is residual disease, then you follow the patient slowly. Now, chemotherapy. There are many different agents nowadays used in the chemotherapy, and there is cisplatin, there is paclitaxel, there is gemcitabine. They are considered the most active, and the standard therapy consists of 2 or 3 or 4 agents. So, you use this combination treatment and you achieve better results with that. But remember, all these chemotherapy agents, they come with their own side effects. So methotrexate, vinblastine, doxorubicin, and cisplatin, we call this MVAC, MVAC. So that is methotrexate, vinblastine, doxorubicin, and cisplatin. So that is MVAC. There is another thing, cisplatin and paclitaxel, that is PT. That is cisplatin and paclitaxel. There is GC, gemcitabine and cisplatin. So gemcitabine and cisplatin, the GC, and GTC, gemcitabine, paclitaxel, and cisplatin. So you see the combinations. But MVAC was considered the standard. But you see, folks, there are side effects like neutropenia, fever, mucositis, diminished renal function. These, and even some people develop auditory dysfunctions and peripheral neuropathy due to these chemotherapeutic agents. At present, GCA is used more commonly than MVACA based on the results of different comparative trials. So you see, the management of bladder cancer, it depends on nature of lesions. Let me tell you again: superficial, invasive, metastatic. If it is superficial, go for endoscopic removal, usually with intravesical therapy. If it is invasive, go for cystectomy with or without systemic chemotherapy. If it is metastatic, go for curative or palliative chemotherapy, based on prognostic factors, with or without surgery. Let me repeat: superficial, endoscopic removal, usually with intravesical therapy; invasive disease, cystectomy with or without systemic chemotherapy; then metastatic, curative or palliative chemotherapy. So remember those three things. If you classify it, it's very easy to remember the treatment of bladder cancer. Hope you got something from out of this, and please visit my website. Thank you very much.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless you.